Hi guys, my name is Morgan Twidwell, and I am a licensed clinical social worker, and I am a certified sex therapist. I have worked in the adolescent psych hospital prior to working here at Resolve. I worked with a lot of teens in my time here. I've also worked with adults and couples as well. And so one thing that is, a regular occurrence here in therapy is self-harm and suicidality. And so I want to take some time to talk about having a strengths-based and harm reduction approach to assessment and intervention for suicidality. So, our objectives for today, I want us to be feeling like we can walk away with understanding the basics of strengths-based approach, as well as the basics of the harm reduction approach. I also want us to be able to walk away feeling like we have some assessment skills for suicidal ideation and some intervention skills as well that align with both the strengths-based and the harm reduction models. So the strengths-based model, what is the strengths-based model? So basically this is recognizing that all of our clients have positive qualities about themselves, and we want to really emphasize and highlight those qualities in order to make them feel confident, to have them feel like they've got a sense of purpose, to promote happiness, um, to put them in a position where they feel like they possess things that are just theirs that kind of make them who they are and can allow for them to get through difficult situations. Um, some of the key points are that we want to view our clients as like they are the people who can promote change in their life. Again, like they possess everything that they need inside of them in order to have change. They have strengths, they have qualities about themselves that will allow for them to do that. We really want to focus on identifying and utilizing those personal strengths. So sometimes people come in and what are your strengths? And people have no idea. But they can give you this huge long list about what their weaknesses are. And so it's as the clinician being able to help identify where their strengths lie as they share with you. I think often the first one is even just courage to have shown up for a therapy session in the first place. And so just really highlighting those and leaning into them in your practice and when you talk to them. Then there's collaboration, community networks, and contextually appropriate solutions being emphasized. So this is collaborating with our safety, our support people. This is identifying, who makes up our clients' community. Is it their friends, their family? Is it a church? Is it work? Is it, you know, people at the coffee shop? Like who is in their world and how can we utilize that for their own personal growth? Um, and then also that practitioners embody and exhibit their own character strengths while supporting clients. So as clinicians, generally speaking, we are patient, empathetic, understanding, validating, calm. And so we really want to lean into those things, especially whenever it comes to suicidality and self-harming behaviors, um, because we want our clients to know that we are a safe place for them to come and talk to. So there can be some pros and cons to having the strength-based approach. Pros being that like it is known to help improve client self-esteem, increase their resiliency, and can give them a feeling of control. Knowing that I have strengths that live inside of me that nobody can take away from me, that I have possessed, that I've either grown into or I've always had, and that have allowed me to get through 100% of the difficult things I've been through this far can be really empowering. Um, some of the cons can be that if there is no focus on what our areas of growth can be, then it can kind of hold people back sometimes. I think that there are moments as a therapist where our clients have these pretty clear and obvious deficits or weaknesses that are putting them in a position to where they can't move forward. If a strength of theirs is that they have really great communication skills, but um, they're drinking pretty often, and when they drink, their communication skills kind of go out the window. If we're not addressing the fact that, okay, well, your drinking is kind of holding you back from being able to utilize your strength, and we're just being like, oh, you're such a great communicator, you do such a good job, then we could be potentially in a scenario where we're not kind of helping them get over that hump of like, what do I need in order to um, like hone in on my strengths and really utilize them to their best ability. Okay, so having this strengths-based approach with suicidality, and wanting to assess and intervene, again, throughout all the time, you want to be managing your own reactions as a clinician. I think it's demonstrating and being a example for what it means to lean into your own strengths. Kind of what we talked about just a second ago, and I'll get a little bit more specific with that here in a minute. And then there's taking a collaborative and empathetic stance. So remembering that our clients are the ones who know themselves the best. They are the ones that possess the skills to change, right? We can educate them, but at the end of the day, we can't make them do anything. And so it's just kind of understanding that you have to collaborate with them in order to um, really understand their circumstances, understand the situation, assess for where they're at, how they're feeling, what's going on. And then we want to identify like the risks and the protective factors. And so that a protective factors being like, what are their strengths? What do they have? Who do they have in their corner? What kind of things do they have internally that can help them? But it's also identifying the risks, like, is it a certain time of year? Is there certain anniversaries of things that are difficult for them to manage? Is it certain people, places, things that can be unhelpful for them? And then we want to focus on their current plan and intent. I think part of the strengths-based approach is recognizing that um, our clients can change and grow over time. So like if someone has a history of suicidality, we don't want to assume that the level of intensity that they experienced 6 months ago is the same level of intensity that they're experiencing now. And so we really want to make sure that we're focused on how they're feeling here in this moment right now instead of kind of overgeneralizing, because I think that kind of takes away from this idea of like empowerment and encouragement. Uh, so and then determining the level of risk. And when we determine the level of risk, that helps us with identifying what we want to do as an intervention. Are they low enough of a risk that they can manage these thoughts and feelings on their own and deal with it? Or are they at a level of risk where they need to start incorporating support people? And are they at an even higher risk of like needing to be hospitalized? So then whenever it comes to the intervention, we really want to focus on developing that treatment plan. How do we like, what are our goals? What are we hoping to achieve? How are we going to achieve these things? And again, having that be really heavily incorporated with your client. So that way they feel like I'm in control of this. These are my goals. This is what I'm hoping to achieve. This is what I feel like I can do in order to achieve these goals. Um, then again, depending on the level of severity, do we need to start involving support people? And again, trying to encourage the clients because they can be resistant to this sometimes, but encouraging them like, it's a strength of yours. Like courage is a strength that you possess. You had the courage to come and talk to me and tell me about these things. You can have the courage to go and talk to your support people, or recognize that our support people are a strength of ours, like that we have a relationship and a bond that is good enough for me to be able to rely on this person. And then, of course, as a therapist, you want to make sure that you're documenting in the way that you can. How did we assess? How did we intervene? What are our plans moving forward? And then also knowing the laws, like what is it that I am required to do? I think this is, looking at your own code of ethics, and also like the state laws and things like that of who must I inform, what action steps must I take, that kind of stuff, depending again on the level of severity. And then also engaging in debriefing and self-care. So I think not only for the client, but also for yourself as a clinician. Um, these kinds of scenarios have the potential to be really taxing. Um, Not only on the client, but also on the clinician. So I think that it's important in order for you to show up as your best self and utilize your strengths the best that you can, you need to allow yourself time to kind of get back to that neutral state and feeling like, you are at a position where you're able to perform at your best. So assessment. So I touched earlier about on the clinician's response. And I think when we're taking the strengths-based approach, that it's really important for us to be behaving in a way and responding in a way that is still acknowledging our client's strengths while they're also in probably one of their like weakest moments. And so that's by us remaining calm and being empathetic and normalizing this response, right? So we know that suicidal ideation is a symptom of depression. We know that suicidal ideation can be impulsive. So we know that when people are in elevated states of emotion and they're feeling like flooded and they're overwhelmed, that suicidal ideation can feel like the quickest and easiest method of getting rid of all of these feelings, right? And so we want to normalize with our clients that this happens. They're not the only one, but also that just because this is happening doesn't mean that they have to act on it, that they can still be safe and feel this way and have these thoughts. We want to be non-judgmental because, again, we don't want to take away from a client and have them feeling belittled or have them feeling like they're in a situation where it's almost like punitive. Um, because our clients understand the risk of sharing this information. They know that I'm running the risk of being hospitalized. I'm running the risk of you telling my parents or telling my spouse or whatever. And so we want to create a space where they continue to feel safe in sharing, and that you are putting them in a position where it's like they're feeling like they are also a part of the process and making the choices that align with what they want, which is, being safe, reducing harm, leaning on the people and the things that they have around them. And then also, whenever it comes to assessment, you want to be able to balance our symptom questions with our wellness-oriented content. So I know that a PHQ-9 is like a really common assessment tool that people utilize with suicidal ideation, which I think is great. I think that those are necessary. A strengths-based way of utilizing a PHQ-9 could be that you are utilizing the questions from the PHQ-9 in a more dialogue narrative kind of way, instead of, okay, you just told me that you're having suicidal thoughts, which is probably really difficult for you, probably feels really vulnerable for you. You're probably feeling very emotional right now. Here's this paper, fill it out. That is very clinical. That can take away from the emotional well-being that a person is having. They can feel like they're now just like under a microscope. And so it's collect that information, but do it in a way that feels a little bit more natural. Um, do it in a way that feels a little bit more communicative, weaving it in and out of like, how are you feeling right now? Like, what are the emotions that are going through you as we're talking about this? And like continuing on. Um, Again, doing this helps them to feel like they're being heard, they're being validated, and they're not just being like judged for having these thoughts and feelings. So when it comes to the intervention with a strengths-based, or I'm sorry, yeah, interventions and having the treatment plan, and adopting that strengths-based mentality while creating a treatment plan, you really want to look at the person as a whole human. And so you don't want to just be looking at them as, you know, just someone who's experiencing suicidal thoughts right now. Like there are so much more about them. And when we look at them as a whole, we're able to identify even more strengths that they have. And so first it's like addressing their emotional needs. So do they need to be journaling? Do they need to be having therapy appointments? Do they need to be um, having hotlines to call? Do they need support people to talk to? Do they need to scream in a pillow? Like, what do you need to do to address your emotional needs? What do you have? What strengths and things and spaces do you currently have in place in order for you to be able to do that? Um, then we go to like their cognitive needs, their thinking patterns, what's going on in their mind. How can they reduce um, the anxiety and that sense of feeling flooded in those moments? Um, so if that's something like um, needing to, take a cold shower, if that's, kind of working through like, what steps do I take in these moments? Like, I know I have a plan. What is this plan? How can I kind of track those and follow it? And then there's the interpersonal. Who should I be around? Who should I not be around? Who can I go to for support? And who do I feel like is not super helpful? And being intentional about like knowing where to go. Who can I call? Who could I text? Who can I visit? Who do I have at school? Who do I have at work? Who do I have at home? Um, because a lot of the times we have people. And so it's recognizing that that's like a positive for us. Even if we don't feel in super duper close to them, there's generally someone around that we feel the most comfortable with that we could go and lean on. Then it's the physical, not only our physical space, but our physical bodies. Do I need to remove myself from a certain place? Do I need to take myself out of my bedroom? Do I need to leave my house? Do I need to take myself away from these things that are tempting me to harm myself? Do I need to cool down? Do I need um, to get in my comfy clothes? Do I need to release some physical tension? What are action steps I need to take to address my physical environment and my physical body? Then there's the cultural and spiritual aspect, right? Like that can be prayer, that can be meditation, that can be music, that can be um some, you know, cultural like meal that's like my feel good meal that makes me feel, you know, like happy and promotes like positive emotions and positive memories. Um, leaning into like what is it that I already believe and that I already have around me and myself that can help me out in these situations. And then behavioral. Are there action steps that I need to take? Um, are there things that I need to do? Um, to get me out of this situation? Do I need to work on my communication skills? Do I need to identify like when I'm starting to feel worked up? What are my warning signs? Do I need to, um, keep my room clean? Do I need to, um, make sure that I'm doing work or homework for at least 30 minutes every day so that I feel like I'm staying on top of things. Like what are behavioral changes that we can make to help like reduce our risk moving forward, um, and just to help keep us safe. So now we want to move on to the harm reduction model. And so this is about incorporating a wide variety of strategies and safer techniques to help manage use of drug use, self-harm, suicidal ideation, um, or trying to work towards abstinence. So that way we can promote the dignity and the well-being of people who engage in these things. So a lot of this is just kind of meeting clients where they're at. It's trying to take steps towards just a safer life, and figuring out how can we really um, put ourselves in a position to where we are, even when we feel tempted and whenever we're finding ourselves struggling to um, not act on our impulses, or if we've had these coping skills for such a long time, um, what can we do to feel like we're making progress and not expecting just like complete like cold turkey change. So again, there can be some pros and cons to the harm reduction model. So pros being that it is evidence-based, and it is proved to be effective. I think that this model feels way less overwhelming to clients, because I think that the idea of stopping all of these behaviors, um, just cold turkey, I think that that feels really intimidating and it feels like impossible to some people. And so, doing this puts them in a position where they feel like, okay, like I can actually take baby steps, and um, that just feels possible to me to take the little steps. The cons are getting support people and caregivers to buy into this. Um, I think that a lot of people really struggle because they're seeing the destruction and the disruption to their loved ones' lives, their own lives. And so they just want it to stop. And I think that there's also a lot of talk about like having boundaries and not being enablers and stuff like that. And so I think that it's common for people to feel, for caregivers to feel like they are enabling behavior whenever they take a harm reduction approach. Um, and that can be a really difficult thing for a caregiver to accept. And so I think it's also about trying to figure out how to get them in on it too. Okay, so assessment for suicidality, having that harm reduction approach. Um, First off, you want to view them as a person first. I think that that's one of the really big things with harm reduction is it's not only how can the client like take action and steps towards reducing harm, but it's also how can the people around them reduce harm. And so a lot of it is by like being non-judgmental, about being really accepting, about it's similar to that strengths-based approach where like we're taking a calm and empathetic and non-judgmental approach because we don't want to be adding harm to a situation. So like really viewing them as a person first who has emotions, who wants help, who needs help, and not looking at them of like, oh, here we go again, like you relapsed um and now I'm just like frustrated with you or the situation or whatever. Um, and then then it's assessing for the risk. And so, because we're trying to take that harm reduction approach, we really want to be identifying like, are you engaging in substance abuse, SI, self-harm in ways that is like high risk, high level of harm, potential hospitalization kind of things? Or are we engaging in ways that's like, okay, we're still engaging in the behavior, but we're doing it ways that's safer than what we were doing before? And really acknowledging that when you can see those subtle shifts in how they engaged in the type of self-harm or suicidal behaviors. And then, like I said, meeting them where they're at, right? Like not, when you are assessing it, that you are remaining, I don't want to say stoic, but that you're staying calm and that you're, keeping your own reactions at bay. Um, so that they don't feel like you're judging them for not being at the place that you hoped that they would be. Or that, oh, we've been talking about this for some time now, and then you went and did this, and like you resorted back to, where you were at 3 months ago. And um and having that feel that level of like almost that you're disappointed in them. You want to try to minimize that. So again, that you're not putting harm onto them, and kind of empowering them. And then you want to express gratitude for them having the confidence and trust in you to share. This is a really big one. Again, it's as a clinician playing an active role in harm reduction and recognizing that it takes a lot of confidence for someone to come and talk to you about this. Because like I said before, like they understand the risks, and that can be scary to even bring it up when you know what the risks can be. Okay, so assessing for the risks. So we want to identify like what are our triggers. And so is that people, places, things? Um, of our triggers, what can we avoid, change, modify versus what triggers can we not really change? Um, and then how can we shift those into a place where we're going to have the least amount of harm? So, especially with the triggers that we can't get rid of, like let's say it's a teen and their mom is their trigger. Well, you live with your mom and we can't really remove your mom or you from the house. If I'm at work and we kind of go through these waves of like my workload being like really high at times. We might not be able to avoid that from happening, but what can we do to try to minimize the harm so that we're not getting to the point where we're feeling the need to engage in self-harm type behaviors or substance abuse or having suicidal thoughts. And then it's assessing the environment. So do we have access to weapons? Do we have access to medications? Do we have access to things, to substances? And what is the level of risk there? So, and how can we try to mitigate the risk in our environment? And then assessing their mental state, do they have a plan? Do they have intent? Um, are they expressing like, I genuinely want to die? Or are they having the passive, like, sometimes I just wish I could fall asleep and not wake up. I don't have a plan. I don't have intent to do anything, but I'm just like, life feels really hard. Um, and being able to check in with where they're at. Again, this is all kind of part of meeting them where they're at, not making assumptions, looking at them as a human and not just as like oh my God, you're having suicidal thoughts, you're engaging in self-harm behavior. I have to treat you just the same way that I treat everybody else. It's really being a little bit more person-centered and focusing on who they are, where they're at, what they're going through, and not just like overreacting because it can be kind of like a scary thing. Okay, so treatment for suicidality. So we want to have a safety plan. Um, One thing that I really like here at Resolve is that we have little safety planning cards printed out, just with different questions like our coping skills, our people, our places, things like that that are listed on these. That it's just like a note card that we can easily fill out in session and that we can provide and have our clients take home with them, um, so that it's easily accessible. They regularly have access to it, and it can put them in a position to where they're feeling like they have already very quickly have a tool in place for them, to utilize in levels of distress. We also want to talk about delaying our urges, um, and finding healthy ways for us to kind of like ride the wave of emotion, um, to help with managing the impulsivity component that can be associated with SI, self-harm, and substance use. We want to ensure that we're restricting lethal means, so that weapons are locked up, key is on someone else's body or with them at all times, that there's no bullets in the weapon, and if they can be stored in a different place, that would be even better as well. Then also when it comes to medications, not having unlimited access to the medicine cabinet, um, using those like weekly pill container things, because even if someone were to overdose, but they only had 5 to 7 pills to overdose on, um, like it's not ideal, but that's far significantly like less of an impact than if they were to take 20 of them. So having those like boundaries and limitations, or it can even be that you have a family member that is like administering your medication to you as well. And then um, finding ways to reduce harm. So we'll talk a little bit more in depth about that, but this is again that mentality of meeting them where they're at, and not expecting complete like abstinence from them, but identifying ways that we can um, put you in a position where you're less likely to have uh, accidentally or intentionally like have like a lethal situation. And then providing access to clean and appropriate implements for self-harm, um, having access to first aid supplies, and really heavily engaging in self-care after this surge of emotions has passed. Okay, so like I talked about with safety planning, it's important for us to have our coping skills available to us, know who our people are, where our places are, and identifying our reasons for living. I think that the coping skill, people, and places, it's really important to make sure that we have coping skills that can be applied in a variety of places. Because for some people, a coping skill might be, taking a cold shower, but like unfortunately, we can't do that while we're at work or while we're at school. So making sure, and like while that may be your number one coping skill, like we need to identify like, okay, well, what are other ones that you can apply in different settings, so that way that they are safe in, or have tools at least for a variety of spaces and places, and then identifying like where are my people everywhere I go. So if I'm at school, if I'm at work, if I'm at home, if like who are my friends that I can go to, do I have like what's access to my therapist like, or hotlines that I can call, um, or even if it's just places that it's like, I'm not necessarily here because I need to like talk to anybody, but like this is just my place where I feel safe and I feel comfortable and I feel at ease. That could be a coffee shop, that could be a park, that could be the gym. It really doesn't matter where, but it's just that it's, providing you that sense of safety that you need. And then reasons of living that can go with us everywhere we go. So, from everything as, from a pet to family to I've got a vacation coming up that I want to go on. Then delaying the urge. So this one is really valuable and important, because like I said earlier, emotions are like a wave. We know that they peak and that they crest and then that they come crashing down. And so, and I think statistically speaking, I'm probably going to butcher this number a little bit, but I want to say, actually, I don't even want to say the time limit from when someone has a suicidal thought to when they act on their thoughts it's a very small window. And so if we can, when I'm feeling these urges, if I can set a timer for 15 minutes and I can just go and do something else for 15 minutes, we are significantly reducing our chances from acting on these thoughts and feelings. There is a level of impulsivity associated with SI and with self-harm and with substance abuse. And so if we can put ourselves in a position where it's like, okay, I've got this timer, it's 15 minutes, I can do anything for 15 minutes. And once that time is up, then assess how I feel from that point. If it's, I need to create some physical space from where I'm feeling unsafe. I need to leave my bedroom. I need to leave my house. I need to take a walk in the outside of my office. I need to go and see the school counselor for a few minutes. Um, whatever it might be, to where you feel like you are creating that physical distance for yourself. Then there is also an app called Calm Harm, and this app can be utilized for people whenever they are feeling those peak of emotions, to help them kind of get through those urges and to calm them and get to a more calmer state so that they do not act on these behaviors. This app is great, but you could also do something like a game on your phone. It could serve a similar purpose. Then there's also the reducing harm component is um anatomy education. So like for our people who are like chronic self-harmers, we want to teach them like where are areas on their body where they're going to cause the least amount of harm, where they could accidentally create a situation where they've cut too deep, they've cut tendons, they've cut arteries, and now they're losing way more blood than they anticipated, or they have significantly damaged their hands because of the tendons that they've cut, or they, have used objects that were like not having appropriate objects and instruments, to where it was this really dull pair of scissors I've torn at my skin, and and this was dirty, and now I'm running the risk of getting an infection. So it's like trying to provide those appropriate instruments as well, so that way again, it's part of that harm reduction. Like, yes, maybe we're still engaging in some self-harm, but we're doing it in a way there's less risk involved on the back end. Um, Along with the anatomy education, like, the front of our arms, our wrists, can be a more dangerous place to engage in self-harm, whereas like our more shoulder and bicep area could be a safer place because there's more like muscle and fat. We're not having as much direct access to like tendons and veins and things. Naloxone is a good one too to have on hand for people who might overdose. Again, it's like wanting to have access to those things so that way, if there is an overdose, that we have things accessible to us to ensure our safety. This can be like people who engage in risky sexual behaviors, that you are providing them with condoms and contraceptives, so that way they're having safer sex and we're reducing the potential harm of STIs, or HIV, pregnancy, those kinds of things. It can be lock boxes for medications, like we talked about earlier. And it can be things like finding, like snapping myself with a rubber band, where it's kind of creating that sting of pain, but it's not as damaging to my skin as cutting might be. Okay, we kind of talked about the appropriate instruments already. Again, this can be a hard one though for caregivers to digest. Because again, I think a lot of people feel like that's them enabling. Um, but really the big picture is, unfortunately in my time as a therapist, I have come to learn that like if someone really wants to self-harm, they're going to find a way to do it. And do we want them to do it in a way that's going to leave a smaller scar and not be infected? Or do we want to have them do it in a way that's like could cause more damage to their skin and they're running the risk of getting an infection? Because it's like if we're removing all of the sharps from someone, which I don't think that's a bad thing to reduce them for sure. Um, but they found a screw in the wall, and so they're gonna take it out and use that screw, which could be rusted and, you know, dirty and all the things. So it's just kind of weighing the pros and cons of those things. And then having first aid supplies. So I think it's important for it to be like easily accessible to people. Something that they maybe keep in their room so that they don't have to even deal with like the embarrassment or the shame of having to go ask for it or having to go into the bathroom to go get it. They can just kind of quickly address it on their own. And then this would be something that like you're not like regularly monitoring and being like, oh my God, I noticed a Band-Aid was gone. Have you hurt yourself again? Um, it's just kind of like I am doing this as a support for you and trying to provide you the things that you need in order to be as safe as you can be. Okay, so one of our last things here is talking to our caregivers and our support people. Like I said in the beginning, their buy-in can be really difficult to get. Um, and to be completely honest, I think that a lot of caregivers and support people should probably be in therapy themselves, with being able to try to manage their emotions and their experience with this because it can be very taxing on them as well. But they can also play an active role in harm reduction with their loved ones. And so, um, really talking with them about emotion regulation skills and about how to communicate to their loved ones, especially when they feel safe enough to come to them and share. And so one thing is this is kind of an outline of how to communicate to someone after they have come and shared with you that they have self-harmed, they have made a suicide attempt, they have relapsed with substances. So first and foremost is addressing safety. Did you recently just inject medicine? Are you actively bleeding? Are you in pain? Do we need to, you know, uh, bandage a wound? Do we need to take you to the hospital to um, get your stomach pumped or something? So that is like first and foremost. And addressing with them, like, do you feel safe? Like, are you, where are you at mentally? Do you feel like you're at a place now where you um, have kind of calmed down from what you're feeling, or are you still really activated? Where are you at? Okay. Then it's about having praise and making sure that they know that you are appreciative and grateful that they have come and shared with you. This is going to be so reassuring and so validating to them. And it's going to make them feel like they can be safe to come and talk to you and not feel like they're going to get in trouble every time that they come and share these kinds of things with you. Um, And I think that that's a really big reason why kids especially won't talk to their parents, or even why spouses won't tell each other or talk with their friends or whatever it might be, is because they're afraid that their loved one's gonna be disappointed in them. They're gonna be mad at them. Maybe they might get in trouble. Um, or now their support person is gonna be panicking and incredibly emotional themselves. Then it's offering support. Okay, so talking to them like, okay, what triggered you? Like, what's going on? What are your needs? How can I help you? Do you want to, what do you want to do to help get to a more neutral state? And I think it's really important for this to be led by the person who expressed some kind of SI or self-harm. I think that incorporates kind of both of a strength-based and harm reduction approach of I am letting this person identify what's good for them and what they need. And I'm also like reducing harm by making them feel like I know better than them. Another thing is taking action. So if you discover that your kid feels really triggered when they go to grandma's house because she's really inconsiderate, doesn't really believe in mental health, and can say things that are not very nice. And you say, okay, well, then we'll stop going to grandma's house. Well, you have to really take action and really mean that. And it doesn't mean we'll stop going to grandma's house for 2 weeks. It means that we're really going to stop going to grandma's house. If you can't promise that, then it's being pretty honest and upfront about that. And talking about how we can minimize it, how we can create a space where you feel more comfortable when you're there. You might not feel the most comfortable, but you feel more comfortable. Or how I can talk to, I'll talk to grandma about XYZ. I'll stand up for you while I'm there. Those kinds of things. Um, and really following through with whatever it is that you say. If you say that I'm gonna talk with your school about ways to help you, if you say I'm gonna, you know, be more intentional about spending quality time with you, and then you don't do it, you're creating a situation where the person experiencing SI is losing trust and confidence in you and feeling like you don't really find their needs that important. And then the last thing is self-care for the support people. Like I said, this can be really difficult for support people to participate in because they're having their own set of emotions. They're feeling scared. They're feeling unsure. They're panicking. They don't know what to do. And so you really want to teach them how to take care of themselves afterwards. And that very much could mean that after they have this interaction and they've held it together this whole time, that they go for a drive or go to the room and bawl their eyes out. And like, that's okay. That is reasonable. That is to be expected. It could be things like, you need to take a bath after this. You need to schedule your own therapy appointment. You need to go talk to your own support people. But making sure that you're taking action, for yourself. So then again, you can get back to a regulated state where you are showing up as your best self for the person in need so that you can be intentional about not providing more harm and for not making the situation worse for them. Um, and just also really focusing on yourself and realizing like this impacts lots of people. It doesn't just impact the person who has the SI. So following this outline can be really helpful, really valuable for both the support person as well as the people who are experiencing SI. And I like this graphic just as I got this from a coworker of mine. So it's, I think, a really great outline to follow. All right, so if you guys have any questions, please feel free to email Resolve, call Resolve, go on our website. I've got my bio on there. My email should be on there if you guys have any questions for me. Um, please don't hesitate to reach out. I appreciate you guys taking your time with me. Hope you guys found this valuable. Um, thanks so much. Have a good one.